Today, it is my distinct pleasure to introduce tech innovation leader and trusted public health expert, Dr. Vin Gupta. Dr. Gupta was the former chief medical officer of Amazon Pharmacy, where he led initiatives that propelled the world into the future of healthcare. Now, the managing director of healthcare innovation at Manat, Dr. Gupta continues to lead teams to advance healthcare technologies. In addition to being a tech innovator, he is also a practicing physician and affiliate professor at the University of Washington's Institute for Health Metrics and Evaluation, and he is a commissioned officer in the Air Force Medical Reserve Corps. As one of the nation's most trusted voices in public health, you may also recognize him from his insightful appearances as a medical analyst on NBC News. Dr. Gupta sits on several boards and has held research roles at the CDC, World Bank, the Center for Global Health Engagement, and Harvard Global Health Institute. He's advised some of the world's largest companies, including Apple, the NFL, and Major League Baseball. He's a powerful voice in healthcare and tech who is helping organizations think big and create their next breakthrough. Dr. Gupta has graciously agreed to take a few questions after his lecture and will refer you to the QR code on his slides to submit questions to us here on the dais. So without further ado, ladies and gentlemen, please join me in welcoming the 2025 Guiteras Lecturer, Dr. Vin Gupta.
Thank you, Dr. Nakanda. Thank you. Hi, good morning, everybody. It's so great to be here. I think I know some of you in the audience. I'm hoping to meet with some of my former colleagues and classmates. But it is such an honor to be at the AUA annual meeting here in Las Vegas, day 2. Lots to talk about, lots of ground to cover, so I'm going to dive right in. And you know, as a pulmonologist, definitely not. The vibe here is going to be slightly different from what I just witnessed over the last hour. Nice reminder of early mornings during medical school. On my surgical rotation. I did honor my urology rotation. It's a nice reminder, the only thing I honored on the surgical side back in many, many years ago. But there's a lot to talk about. Obviously, there's a lot of, you pay attention to the news cycle at any moment. Lots of challenges, lots of problems. And I think we can get caught up in the cycle of doomsday, doom and gloom. So many things out there. And I'm not going to do that. Across sort of health technology, bedside care, and everything in between, I do think that we're in this moment where we can actually talk about real solutions. And everybody likes to talk about healthcare technology, generative AI, future of healthcare. I know there's a lot of sort of those cross currents throughout this meeting, as they should be. But we have real solutions that are working. And so my hope is, in the time that we have, and I'm hoping that we have discussions, so please ask questions through that QR code, that you'll feel like there's actually something there for your patients before potentially they need the OR for one of the many things that you do so well. And there's so much expertise and surgical skill in this room. But I'm going to be talking about a lot of the patient experience prior to somebody actually seeing you in clinic and potentially needing your expertise. But in the tee-up, and I'm actually going to go back and see if we can try to replay that. What did I just show you? It's where we're headed. What is the context right now for the United States and the world? You probably just saw that red bar, that 65-plus red bar, for those that can see it, and hopefully this projects to the very back. That's the oldest part of our society. And what we've seen is, here I'm going to just kind of re-show how that's changing over time, but this sort of concept of demographic decline gets talked about a lot. And what we're seeing is that by 2027, so in this decade, we're going to be where South Korea and Japan were about 15 years ago. I know this is a global audience, so I'm not just talking to the Americans in the audience or those from North America. This is a global discussion. And what's happening here in the United States is obviously evocative and resonant of what's happening across the world. Our societies are aging. And this is what's going to be happening in just the near future. This is not some off vision of the future that your children are going to have to contend with. No, all of you in your practices are contending, and probably seeing this right now, an aging society. And it's going to happen pretty quickly. And this is going to have all types of impacts when it comes to how we think about benefits, how we think about our entitlement programs. Who's going to pay for that? Taxable base. You know, this is not stuff that I think we consume a lot in medical school, in training. We don't have time to do that. But this is impacting every one of your patients in some way, and it's going to continue to impact them over time. And, you know, staying clear of things, fault lines that are obvious. You know, we don't always agree on things, especially in the healthcare setting. We're seeing that. I think the pandemic showed those points that really riven society. We don't agree on a lot that I think we thought we all agreed upon. Harrison's, for those that are, if you remember taking your internal medicine clerkship, those books filled with clinical facts no longer have the same resonance and meaning to broader society that they used to. We're getting older. We're getting, obviously, a little bit more divided on core beliefs, and we're getting more digital. There's a lot of convergence of factors here. And yet, you know, choose the stat, and I'm sure you're seeing this in your own practices across all the academic medical centers that you work with, all the health systems, community clinics that you might have a presence in. We just don't have enough human capital. You know, I find it interesting that when I think about health policy, the conversations we are having, and then the conversations we're not having. One of the conversations we're not having is, how do we actually meaningfully address this problem here? I just told you we're getting grayer pretty quickly. This is not, again, not happening in 20 years. This is happening right now. And by the way, some of you or all of you are experiencing a shortage in some way of a surgical tech, surgical nurse, perhaps support staff in the ICU when your patient comes out of the OR. There's shortages. It's impacting your clinical practice in some way. And yet, the actual ability to train more human capital is being constrained by policies that were first formed in the 1960s by Congress and have not been revisited. How many residency slots do we have to train, say, more urologists, more radiologists, more primary care physicians? A lot of that has been constrained by policy that was inculcated 60 years ago and has yet to be revisited. So this is the tee up. And, you know, often people will say, well, gosh, of course, you know, doom and gloom. The tee up here is not optimistic. The solutions are. So we're going to get there. But for all of the money that we pour in across the spectrum of healthcare in the United States, whether it's advanced subspecialty surgical services, whether it's in the ICU, you know, 40% of healthcare costs in the United States are in the last 3 weeks of life. Dignified dying in a medical or a surgical ICU. That's where we spend most of our money. It's a broader conversation on how we tackle that problem. We don't have enough time for that, nor perhaps is this the right venue to have that. But this reality is the reality I think we all have to contend with. Why is it that we're not getting performance or objective ROI on all the money that we're pouring in per capita on patients across the United States? We spend $13,000 per capita per patient in the United States. We are not getting ROI. Life expectancy, healthy life expectancy, whatever metric you want to use, has not shifted. If anything, it's probably gone in the wrong direction relative to our peer economic countries. So we have a lot of issues here that we have to deal with. No question. Compounded by current events, compounded by the ways in which we may not agree with each other on foundational facts. How do we actually navigate all this? That's the issue here. I'm going to show you, you know, it's one burn after another burn after another burn on all these challenges. I'm going to show you a video shortly on the ways in which we actually dealt with cascading crises during the pandemic. I had a front row seat in my role as a reservist for the Air Force, and I'll show you how we actually dealt with this. Cascading crisis after cascading crisis. What did we do? We deployed the United States military, and that's what this looked like here.
Quietly and unknown to most of the American public, the U.S. military is preparing for a new era of national security threats. This operation isn't aimed at taking the fight to the enemy. It's aimed at saving lives of the critically ill.
So you have a ventilator, you have a monitor, you have an IV pump, so really a mini ICU.
Exactly.
Dubbed Ultimate Caduceus, the exercise simulates the rapid transport of severely injured troops from battlefields around the world to advanced care centers back in the U.S. It's a mission I've seen up close and personal as a reservist ICU physician leading a CCAT team of my own here on the West Coast. Aboard military aircraft, soldiers turned patients are transferred and stabilized in these flying ICUs, saving lives and fulfilling promises.
The American people have entrusted, their sons and daughters to defend our nation, and when they become wounded, ill, or injured, to be able to bring them home safely is really the purpose.
Medical readiness is just one more way that the U.S. military shows the world the physical and strategic health of its force.
How does this increase the survivability of injured soldiers downrange?
Oh, it's huge. It's huge because we essentially take the level of care that they can expect in a U.S. ICU. We bring that forward to the front line.
With tensions rising in the Asia-Pacific theater, the war in Ukraine, and the threat of pandemic, this is a necessity, not
a luxury. Got cut off there. But really the question here is, how do we not recreate September of 2021? This is a picture, sort of the back picture there is the picture of a C-130. And it's a military aircraft here in the United States. It's replicated across the world, actually, for those of you who might be from somewhere else. And what we saw here is that this actual aircraft, the bay of this actual C-130, 3 months prior to this was used to evacuate U.S. forces from Afghanistan. 3 months later, my team, other teams across the country were using this to actually transfer COVID critically ill patients from a non-ECMO ICU to an ECMO-capable ICU. That's how we were caring for more with less. We were deploying the United States military. And so when I talk to you about these cascading crises, grayer society, we're more divided, we're more digital, we don't have enough people because there's so many reasons why people are not entering primary care specialties across the country. We have many, many reasons. And oh, by the way, we have all these cascading crises and a news cycle that seems ever more pessimistic. How are we actually going to deal with those problems so we don't deploy the U.S. military? This is, by the way, a model that other countries replicated as well, and it's not financially sustainable. It's your taxpayer money, $500 million every single year, going to sustain this capability. And obviously, it doesn't scale. We're talking about 1 or 2 patients here or there. This is not a strategy. So how do we actually deal with this? What are real solutions? All of you, I'm sure to a degree, are in health systems and clinical settings where you are getting pitched by vendors constantly about the latest, greatest tool to use in the OR, to augment the discussion that we just had on how do you deal with your ureteral injury, any number of things. And there's a way forward here. There's a way forward to move past point solutions and to actually talk about real technologies that can help us solve these problems. Lack of human capital, how are we going to scale? How are we going to deal with these cascading crises? I'm going to give you concrete examples. Whether it's big tech and Amazon trying to reshape how patients experience healthcare, whether it's a non-traditional entity doing something interesting in diagnostics, we have to think differently about the tools that we have available to deal with everything in the tee up here. So I'm going to focus on these conditions. Again, stuff that you either directly deal with as urologists and as a urological community when it comes to, say, bladder cancer. How do we detect that earlier? In this case, hypertension. How do we detect that earlier? It's the leading risk factor for death and disability in the United States and worldwide. How do we actually meaningfully screen for that earlier so that we can get people into care earlier so that we can get them treated? And here's why that matters. When we think about how do we do more with less, I want you guys to look at this chart. This is from the University of Washington's Institute for Health Metrics and Evaluation, the Global Burden of Disease Study. It gets updated every few years in the Lancet. The 2025 results are coming out pretty soon. But what you're going to see may not surprise you, which is that the same risk factors for death and disability in the United States and across the world in 2019 were the same as they were in 2009, were the same as they were in 1990. And look at the top. It's high blood pressure. As a pulmonologist, I sit on the board of the American Lung Association, it's still smoking. We wrestle with that all the time. Why is it still smoking? Well, it turns out in relative terms, we're actually doing pretty good when it comes to reducing the relative frequency of people smoking across the world, but it's still a huge problem. But that number one problem there, high blood pressure, I'm going to key in on. Because it's the reason why ultimately people end up coming to see you in certain cases, or your colleagues, Or my colleagues on the medical side. There's a cascading problem here of undiagnosed risk factors like high blood pressure that then ultimately cascades into a real problem here. Some of you may have seen JAMA actually published in January of 2025, just a few months ago. 60 million adult Americans across the country have stage 2 hypertension, it is estimated, and they don't know it. The ultimate silent risk factor for heart attacks, for strokes, everything in between. It's because we don't have good screening tools. And that's number one here. That's why I want to talk to you about why we need to think differently about hypertension, how that's going to help us care for more people with actually less human capital. And hopefully I'll be able to tie those threads together, and I'll explain to you what you're seeing here in a second. But often it isn't North American countries, the United States and others, that are leading when it comes to really pushing the envelope on health technology and innovation. We're often following. And this example here is actually a great use case. We are terrible at diagnosing the leading risk factor for death and disability in the United States and worldwide, by far. We're terrible at it. Early diagnosis, early intervention of high blood pressure is an impossible task in the United States because, turns out, people do not like the tools that are available to them. We're taught in medical school to use a validated, FDA-validated blood pressure cuff, like the Omron blood pressure cuff. Nothing wrong with it. Works great. But what we found out, these are conjoint surveys we did with Amazon back in 2021. Turns out 9 in 10 people diagnosed with high blood pressure do not like just the physical experience of having their arm squeezed. They do not like their brachial arteries squeezed and the sensation of that, feeling the pulse. These are actual direct quotations. They don't like it. They might be on lisinopril, they might be on Lasix, they don't care. They're not using that machine next to their bedside to measure what's happening with them. Imagine then using that same technology. That's the same exact technology that we're saying, gosh, we should be providing this to more people, covering it to the tune of $80 a pop for every patient across the country, but they're not going to utilize it. They are not utilizing the tools that we have been trained on to diagnose and screen for illness. And so what's happening in places like Israel, South Korea? That's the facade of a Samsung refrigerator in South Korea. Places like Switzerland, what's actually happening? Well, they've recognized this. And unlike the US FDA, I'm very close, I'm a mentee of the former FDA Commissioner, Bob Califf, who was a cardiologist. Him and I have a constant conversation about why is it that we don't leverage the technology that people wear on their wrist, underlying technology, photoplasmography. It's in your O2 sensor, it's in your favorite wearable. Why don't we use it in the ways that other countries across the world are utilizing it to actually better give us a sense of what's happening with their bodies? And that's exactly what they're doing. In places like Tel Aviv, this is a smart mirror in a hotel room in Tel Aviv. For those of you who may have been in Tel Aviv recently or hail from there, it's an amazing hub of medical innovation. They are doing things with technology that is on your wrist right now or that your patients experience with an oximeter. They're doing interesting things that are acknowledging tech as it exists today. The possibilities to reimagine a better patient experience. And so what's happening here? It's not different from what was happening on that prior screen with the app on the iPhone or your favorite smartphone. Essentially what's happening is this person's waking up in the morning and they're getting a biometric scan using photoplasmography, the same exact technology that's in, again, a skin-based sensor. And what we've realized is that photoplasmography, the act of actually shining electromagnetic waves into the skin and then getting refracted waves back, and then utilizing machine learning algorithms to actually back calculate things like O2, heart rate, respiratory rate, blood pressure, what we've realized is that people actually don't need skin-to-skin contact for photoplasmography to work. You can shine it from a smartphone app. You can shine it from a facade of a Samsung refrigerator in South Korea or from a smart mirror in Tel Aviv. And it's going to give you, we have to gamify it, and it's a 30-second exposure. We can't guarantee that people are going to pay attention for 30 seconds, so they have to click and do all these things. But if they get the 30-second scan, what ends up happening? We get blood pressure, we get heart rate, we get respiratory rate. I'm not going to go through a photoplasmography session with all of you because that's not the purpose here. The purpose here is for us to acknowledge a basic fundamental truth about what is working and what is not working right now in medical diagnostics and how that's actually dating back to our upfront thesis. How do we do more with less? There is a reason that I'm going to take you back to this burden of disease slide here. There is a reason high blood pressure remains the #1 killer of humanity. It's because we do not diagnose it early, and the reason we do not diagnose it early is people do not like the screening tools available to them. They don't scale, they're very expensive, and what's the point then? If people do not know they have this until it results in something that's distal and severe, what's the point? We make ourselves feel good thinking that we have these tools available to us, but people are not utilizing them, hence a different approach. This is yet another different approach. This concept of ambient diagnostics for something like high blood pressure. Well, let's envision how do we actually integrate more things into the lives of our patients? Well, no better way than actually making the time in the restroom or in the bathroom as efficient as possible. And this is what's happening with the heart seat here. Embedding sensors like the EKG, balisocardiogram that actually can measure blood pressure, PPG, we already talked about that. That can do both blood pressure and oxygen. Internal batteries, Bluetooth connectivity. This is being developed by cardiologists across the Longwood campus with partners. But the idea here is something very similar to the smart mirror and everything that I was talking about that, oh, by the way, is not a point solution. I'm not trying to give you point solution fatigue. I'm trying to push us to say, along with our leading agencies that look at compliance and regulatory, look at patient safety, look at things like sensitivity and specificity, that we need to be thinking differently about how we bring patients into their medical journey. To convince them that, yes, in fact, they are a patient. They have a condition. Well, it turns out maybe if we actually make their home experience as medically friendly as possible, as useful as possible to give them insights into their body. And again, maybe it's actually just by utilizing something like the bathroom, sitting on a toilet seat for 20 seconds, or brushing your teeth in front of a smart mirror, we'll be able to actually get the information that we need. And I know some of you will say, well, is this appropriately sensitive and specific? It is. This is actually 95% sensitive and specific for stage 1 hypertension detection. It's going through FDA trials as we speak. And what we're seeing here is this is the actual lived experience of our patients. Look at this. This was back in January of this year. Somebody is clearly outside of control. I mean, it's not terribly outside control, but what we're seeing is that somebody's in the 140s. And they're sort of chugging along. They have a telemedicine visit. Medication has changed. Looks like things are actually getting under better control. They have a telehealth checkup a few days later. Things are under better control. And boom, they're back in where we want them to be. In almost a 10-day span, this device, again, I'm giving you the hope-for, optimistic view here, that people want this. This is the actual way to embed it. Clinician prescribes it for somebody with high blood pressure. It's installed. It's dummy-proof. People actually come in and install it. Those that can help enable remote patient monitoring. There's an actual service to do this. Televisits, utilizing this data, can actually wrestle with this data, gets embedded into the EHR. A clinician or their MA actually will be alerted if something happens or a patient's blood pressure is outside preset norms. And then you can make changes to medications through, say, a televisit or through a mail-order pharmacy. This is the patient experience. It's not pie in the sky. This is real. And I would challenge all of us to be honest about what this patient's real experience would have been if they didn't have the heart seat available to them, or say if they were in Switzerland or Tel Aviv, what their experience would have been. They probably would have had no symptoms, and they probably would have just gone on their way with worsening stage 2 hypertension, ultimately potentially having a cascading problem 6 months later. This probably would have gone undiagnosed. And yet here we're bringing them under control in a matter of 10 days. This is the problem. We do not have screening tools, much less remote patient monitoring tools for something as basic as high blood pressure that people want to utilize. We have tools. They just don't want to use them. Hence, the nature of our burden of disease. We need cheap, scalable solutions that actually are lovable. We don't talk about lovability and the patient experience. We often talk about engagement. We're going to be talking about engagement in a little bit. How do we engage people in primary care? Why is it that 40% of people between 35 and 54 years of age have never established a primary care appointment? Why? I recognize that a lot of these questions are proximal to many of the ways in which you engage with patients in the OR or a neurology clinic, places in between. But everything that's happening here right now is going to impact your practice. It's going to impact your field. If people are more empowered to understand their bodies at the point of need, at the first time something is wrong, that's ultimately good. That means we don't deploy the US military or wherever any of you hail from. We're not deploying things that don't make sense, that are not scalable, like deploying military assets to contend with a cascading problem. That is not a solution. Lastly, on the topic of high blood pressure, because I think it's so important. This is not sexy to talk about. Media doesn't want to talk about this. This is not something that captures people's attention, and I think that's a bad thing. Because this is actually where the rubber meets the road when it comes to what's actually ailing our health system, and frankly, every other health system across the country. How do we actually bring people into care earlier? It's this problem of delayed diagnosis. We have to be having this conversation more often. And oh, by the way, here's the problem with the smart mirror. This is the conversation I have with Dr. Califf and others on the regulatory side. Years of experience, respected fully. But they want something that's 90+% sensitive and specific for something like stage 1 detection of stage 1 hypertension. And it's not there yet. And you know what they do in places that have adopted this? They've accepted certain realities. That yes, it's not quite there yet. The tech's not there yet. We acknowledge that. But wouldn't it be great to give 85 out of 100 people a sense that something might be wrong if it's 85% sensitive for stage 1 hypertension detection? Wouldn't it be great to tell those people, hey, maybe you should go and get a formal visit? And for the other 15 that we might be actually giving them, say, a false positive reading, what's the harm? So they go and make an appointment or see somebody. Yes, maybe some of them go into the urgent care ER. There is a concern for churn. But if we're saying that we're going to bring more people into care or give them better insights earlier on, I'd say that's a win. And that we have to be, especially in this age post-pandemic, where I think people understand medical risks. They understand more about their bodies than they did, say, 5 years ago, because we've been talking about these concepts for now years and years. We should empower patients and trust them to be able to do more with these technological tools and not be as conservative when it comes to actually launching and learning. They're launching and learning these devices in other parts of the country, of the world. We're not. And I think that's a broader discussion, but that's, especially for the tee up here, if you guys have questions, this is something that I would urge us to really consider. What is acceptable risk? What is acceptable risk when it comes to innovation, launching, and learning? I don't know if we've figured that out yet. I'm going to switch here, but keep on the concept of diagnostics. On my time on the American Lung Association board, something that we always wrestle with is, and I'm going to tee this back up, is why, when we think about cancer screening rates across the United States and world, why is lung cancer screening terrible? Lung cancer is by far and away the leading cancer-related cause of death in the United States and worldwide. There's a theme here. I'm trying to focus on the biggest killers here for a reason, because your time is valuable. I don't want to waste your time. We also have to ask ourselves, why are the things that are happening, why are the realities that we have to wrestle with today, why are they so? And you might say, well, it's obvious, people smoke still, that's why lung cancer is a problem. Or there's air pollution, that's why lung cancer is a problem. Yes, no question. Risk factors abound. But why is it that only 12% of people are getting a low-dose CT scan for lung cancer detection here in the United States? When, by the way, the other 88% of people have it covered and meet criteria. Obviously we're doing better when it comes to breast, cervical, colorectal. We're not 100%, we should be. These are things that we want people to engage with. Because remember, early detection, early treatment. That's not a foreign concept to anybody here in the room. It applies to your practice and your specialty as much as it does to any other specialty. But why is it the case that 12% of people are getting screened for something they have a covered benefit for, and which, by the way, is the leading cancer cause of death in the United States and worldwide. What is going on there? It drives us crazy. Is there an awareness problem? Do people just not have enough time? What is going on? Let's double click on that. And luckily, I think what we're seeing here is that we're actually now making progress. One thought is that people don't have time. We have the tool, we know it works, they just do not have time to make the appointment. It's too tough to get off work, you have kids at home, whatever it may be. But what's the patient experience? We've dealt with this data. I'm going to come back, you're probably wondering, what did I just show you? I'm going to come back to that in a second. But what is driving this reality? Just like, why is it that 60 million US adults have stage 2 hypertension? Vexing. But what we've realized is the act of getting a colonoscopy, much like the act of setting up an appointment for his low-dose CT scan for lung cancer, is difficult. It is not a lovable patient experience. People do not enjoy it. And I know that might cause rolling eyes here in the audience, like, gosh, we work so hard to provide patient care that's high quality, and here I am having to hear that they don't want to get their arms squeezed once a week, or they can't be bothered to pick up the phone and make a radiology appointment for a low-dose CT scan that could save their life, extend their life. Yes, I understand that there might be frustration at the root cause, but this is the world that we live in. And so what are we doing about it? Again, my promise to you, no random point solutions pie in the sky, real solutions that are finding an actual degree of traction, whether here or somewhere else, causing us to rethink how we should be thinking about our practice, the practice of medicine, maybe revisiting prior assumptions here. What am I showing you? I'm showing you these green globs, and these are T cells. And as you know, I don't need to tell anybody in this room, T cells are one of the most powerful assets we have in the human body. They detect something that is that is foreign to our body at the earliest signs, at the earliest stages, whether it's COVID-19, whether it's flu, or whether it's a malignancy. And what have we realized? What are smart scientists at the Fred Hutch and at the University of Cambridge, where that footage was coming from, what are they realizing? They're realizing that, gosh, we should be fingerprinting the response of every T cell. When our T cells get activated, and there's clones of T cells that get activated based on whatever might be happening to somebody's body, let's fingerprint that response. And then let's map it back to various disease entities that are historically impossible to diagnose early. I take the case of MS. I have a few friends that have had to go through the process of getting diagnosed for multiple sclerosis. It is not like high blood pressure. It is not like low-dose CT scans for lung cancer. It is a difficult entity to diagnose early, much less do we feel like we have a set of clinical standards that are standardized. Is it easy to detect? One person's opinion might be different from the next. MS is a difficult disease to diagnose. It's not scalable, the tools to diagnose it. Unlike lung cancer screening and high blood pressure, which, by the way, we have tools that exist, people just don't like them. Anyhow, we have a problem here. How are we actually going to contend with it? We're going to map T cell responses. We're going to fingerprint individual T cell responses and then be able to early detect MS. Pancreatic cancer, historically notorious for a late presentation. You're bloated. Ultimately, you're having GI problems. And in many cases, that's heralding something significant, like pancreatic cancer, ovarian cancer, in that bucket as well. Many of these diseases, lung cancer, hemoptysis as a presenting symptom, we detect these too late. Because most people that we actually should be caring for don't think anything's wrong with their bodies, or don't have the time to make an appointment. That's the problem here. And so what's actually happening now, and what we're seeing, is we can take a small blood sample, 500 cc's. Not 500 cc's, just much smaller than that. And what we can say is 5 cc's. And what we can actually do is on that, if we're worried, or if we want to do sort of just a general assessment of somebody's health, we can, over time, we only have fingerprints for a few actual entities right now. COVID-19, MS, pancreatic cancer, celiac disease, things that, again, we don't have a colonoscopy or a mammogram necessarily available to us to do diagnosis. Conditions that are tough to diagnose. And we can basically take a serum sample, run it against these fingerprints and say, is something happening here? A lung cancer fingerprint is being detected or is being innovated as we speak. And that's going to enable us, hopefully, the hope here is to do something different. You probably have already seen Guardant Health has a colorectal cancer screening test that actually detects DNA fragments from colorectal cancer. The problem with that, unfortunately, is that it tends to detect later stages of colorectal cancer. It is not fantastic at detecting the earliest stages of colorectal cancer. The T-cell response and the T-cell approach is going to hopefully be different. I'm going to switch gears right now, and I want to, we've talked so much now about diagnostics. I think diagnostics gets often left out of the conversation. In health technology, we talk about services, we talk about pharmacy, because that's where there's a lot of money. Diagnostics is considered to be low margin, which is why we haven't seen a lot of innovation. I'm going to switch now and to talk a little bit about, again, how are the ways in which we are going to change as a medical profession to better care for patients in this moment when, again, we have to do more with less. I'm going to show you this video here and meet you on the back end.
Gosh bless him. He came here one day. Oh, he explained everything. He knew everything.
All right, so you have the app installed on your phone now.
It says right here, these are the things you do today. And then you scroll it up here. See, I learned that too. And then here you get, your weight. Don't look at that. And this is the oximeter. This is the pulse rate. And this is blood pressure. If my pulse was down, they would call me. I'll tell you, I was never alone. And of course, I found out Geisinger has people too that will come to your house. I love it. I don't have to go outside the door. They call the doctors and talk to them.
I could reach out to the Geisinger at Home team and see if your results came back.
I am 89 and I am still here to enjoy life to the fullest. Why? Because of the care and my miracle worker.
I just got done telling you that people don't like things on their arms, but it depends on the device, and it also depends on the ways in which we're supporting these patients. What are we seeing when it comes to hospital at home? I'm sure many of you, I won't ask for a show of hands, but I'm sure many of you work at health systems, academic centers that have burgeoning hospital at home programs, and for good reason. Because it turns out, I do my clinical time at an entity that is only dealing with much more complicated patients across the spectrum, especially those that receive ICU level care. It's cardiothoracic patients, it's neurosurgical patients. And it turns out that the space of long-term care has not innovated a lot. It's not like we're building a lot of new long-term care facilities that can care for post-acute patients. We aren't. That market has not grown in any substantial degree to care for the need that exists today. And by the way, that's going to exist as we have a grayer, demographically aging society. The stuff I said in the tee-up. How are we going to care for this demand? We're going to do it at home. And so home is no longer the purview of just, look at your step count. Or, let's finish your course of ertapenem or vanco at home. Or to bridge to, if you're on an anticoagulant, to do some bridging there. No, we're actually doing post-acute inpatient level care in the at-home environment. What are they doing in Virtua? They're actually they're saving bed days for patients across the spectrum, discharging them into a hospital at-home environment. In places like Sarah-Can and HCA Healthcare, CAR T patients are actually being cared for in the at-home environment. Remote patient monitoring, things like what I just showed you, Best Buy for Health, actually has a health geek squad going in, dummy-proofing the whole darn experience for mom or dad or grandma or grandpa to say, hey, we'll set up and enable RPM so that you can get your CAR T and we can look at your vital signs, track things, make sure everything's going okay. Place like Baptist Health. I don't know if anybody here is from Baptist Health. Unbelievable, 90 days. 0% readmission at 90 days for CHFers. I feel like we're chronically always caring for these patients on dobutamine plus drips and any number of things, taking up ICU level beds to some degree or step-down beds. Now we're saying that potentially, maybe we can't care for that in the at-home environment. That's still a significant spectrum of illness. But once we get them off drips, maybe we can discharge them not to an LTAC, but actually to the at-home environment. Things are actually working here. Again, my commitment to you, and I think everybody's commitment to all of you, it should always be Give me what's actually working. Because now we've been talking about future of health and Gen AI and digital wearables for about 10 years. Gen AI has been new. Future of health discussions have been happening since the 2010s. We need actual proof on what's working and what's not working. This is working. But just like with innovating on high blood pressure and on smart mirrors and on heart seats and what's happening in the rest of the world versus what's happening here in the United States, I think we have to be honest about something. Many of you, for those of you that might be in this space, probably know that the waiver to actually allow this type of care in the at-home environment is an extension of the COVID-19 health emergency. Typically, we were not allowed to care for this severity of illness in the at-home environment, at least in the United States. Now what's happening? Congress has basically said, hey, we'll allow that. We'll allow certain waivers to happen so that you can do things within the four walls of a home that traditionally we would not allow, but that's going to expire in September. So when we're talking about how do we care for more with less, in a world in which we're not producing more in relative terms for physicians, nurses, PAs, MAs, how are we going to do that by 2030? It's this. But again, there is a policy component here that I think all of us on the clinical side tend to slightly be removed from, that I think we need to all get versed in more and become much more vocal advocates. It's nuts to me for saying that we're not going to invest in this and make what's right now temporary and constantly getting extended permanent. UMass Memorial, for the UMass Memorial people out there, something similar. This is working. This is not pie in the sky. We talked about the acute spectrum, post-acute care, taking somebody that might be critically ill, getting them actually to the at-home environment, freeing up an inpatient bed for somebody that may be coming out of your OR that needs a few days of monitoring. What about on the primary care side? I wanted to show you, this might not, the small font might not go all the way to the back here, but what are we actually seeing work? Getting people early diagnosis, early treatment. I'm going to trigger back here. What we're seeing now is this movement of asynchronous telemedicine. And some of you may not like it. Some of you may think that this is perhaps risks not being clinically rigorous. But what we're seeing is that people can wake up in the morning with flu-like symptoms, say, hey, doc, I have a fever. I might have a cold. Tell them where they're located, some basic information on their geography, on their medical history, on their medications, and they can do this all asynchronously. And basically what they can then do is get connected, again asynchronously. You're not actually communicating with a doc or a healthcare provider, and get told that you might need to actually get a prescription. For COVID-19, it might be Paxlovid. For flu, it might be Tamiflu. But all within, say, an hour to 2 hours, you can go through the process of initial triage and potentially even getting a prescription for an acute infectious disease quickly on the matter of pennies on the dollar, all from the comfort of your home. And there's a lot of complexities here. Will people like this? Will they trust it? Big problems, big questions. But this is what's happening right now, and it's more than just Amazon. Walmart's doing something in this space as well. Your health system's probably doing something in this space as well, but what's the optimistic view? It's patient-empowered care. I wake up in the morning, I can't get in with my PCP because they're overloaded. They can't care for all the need out there. Boom, I can just answer a few questions at Amazon, pick my favorite virtual care clinic. It's going to automate the HPI for the clinician. If there's a promise, if there's a medication that's needed, it's going to give delivery promise time, price transparency. It's a different way to experience basic primary care, especially at a moment in which the Commonwealth Fund has already highlighted pre-pandemic that 1 in 2 adult Americans, when they are acutely ill and need to see a PCP, cannot get access to same-day or next-day care. I'm not saying this is perfect. It's far from perfect. It is not a solution that is comprehensive. But again, just like a better way to screen for high blood pressure or potentially malignancies, we have to start thinking differently. We cannot keep doing the same darn things. And this is finding traction. Some people love it. They tend to be tech-forward in the sandwich generation, 35 to 54. Again, that same type of patient or that same type of individual that otherwise thinks they're invincible, doesn't need a PCP, they use this. Your patients probably are inclined towards this if they tend to be in that generation. And again, All I'm saying is we have to start breaking down assumptions and pre-existing biases, because all of us, to some degree, got trained in a different world where a lot of this stuff didn't exist, or in which there's high judgment. Oh, well, how is this going to be good care? How could async care possibly be safe? Or how could sitting on a heart seat be possibly effective? It's all nonsense. I hear this from a lot of people that are trusted clinical mentors. Vin, don't trust that. And I think we have to let go of those biases. We have to. We have no other choice. Show you something here real quick. So that's Zipline. Some of you may know Zipline. This is not just a United States thing. This is not just a OECD, rich economies thing. Oh, let's do healthcare at home. Let's do all these things at home. No conflicts here. Just to say that I'm a huge fan of what they're doing. You just saw what they did in a day's time in Rwanda. This concept of healthcare at home is not just for the CHFer. It's not just for the person that's tech savvy and has all these fancy devices and can pay for it. No, it's happening in places like Rwanda. And not just upscale, it's happening at scale. People are amenable to getting their healthcare at home, potentially through drone delivery. This is all medication drone delivery. Again, something that I would say 5 years ago, we'd say, oh, that's nonsense. Why are you talking to me about that? Let me go publish the next thing. No, this is where the rubber meets the road here. We have to be wrestling with that. And my push to all of you is you are obviously all leaders in an incredibly important specialty. You're respected. You spend years honing your craft. What I don't think we have enough of is folks like yourself actually helping to advise and call out what actually makes sense versus what potentially is total nonsense. I have not seen enough of that actual iteration, that dialogue, and we need to change that. I'll lastly close on just home care before we pivot, and then I do want to make time for questions if you have any, so please do. And if you disagree with it, it can all be you can come up. If we want to have a live, I'm sure Dr. Nakanda will be open to just a direct engagement, but if you want on the QR code, you could do it anonymously, whatever you prefer. I do want to tell you, though, again, the commitment here not to give you snake oil. We just published what we did with Amazon Pharmacy in JAMA to say that a better way to experience pharmacy for chronic medications, cheaper. People are saving money, they're getting it fast. Early treatment after early intervention is actually improving medication adherence. Again, a non-sexy problem. 50% of American adults do not take their medications on time as prescribed. We think we actually have an engaging way to solve that problem, and we're not just talking about it. We're publishing in some of the leading journals in the world, and this is actually proof of that. And I would say all of you should demand actual proof. All right, I'm going to close just a bit on Gen AI and just a quick comment on trust. I think everybody here probably has their own point of view on generative AI. You've probably been told what to think about it, have your own point of view, or love it, hate it, don't know what to think about it. But there's far more about generative AI than I think meets the eye. And I think a lot of you are probably already seeing some of this play out in your own clinical practice, which is to say, how do we care for more with less? Well, we got to be better at diagnosis at the point of care. Misdiagnosis happens. Probably not in your spectrum of illness and sort of your expertise, because patients have gone through the ringer a few times before they come and get a referral to a urologist, potentially, not in every case. So we know what's going on with them, or we have a good sense of it. But going into the ER, coming into the ICU, pulmonary clinic, sometimes you just don't know. 100,000 misdiagnoses every single year. Sometimes you just do not know. And how do we care for more with less? Well, one of it's going to be better diagnostics. How do we avoid deploying the U.S. military? One of it's going to be, or any military, is better healthcare at home that actually has a reimbursement mechanism. And oh, by the way, another is going to be better tools at the point of care to make sure that we're minimizing misdiagnosis. And that's the great promise here of generative AI. I'm going to take you through what I mean by that in a second. Show you this video. See you on the back end. So think of Clarity as Google 2.0. You're already seeing on your search queries, choose your favorite search query, but let's take Google as an example, since it's the most dominant search engine in the United States and probably most of the world, which is to say that you're already seeing an AI summary at the top. I have pink eye, or name the medical intent search. You're going to get an AI summary at the very top. What's going to happen before long is you're actually going to be able to engage, if you have a healthcare intent search query, into an iterative exchange that's built on a generative AI model, which is to say I have pink eye, or in this case, somebody asking questions about an A1C level, they'll get a response back, probing them on asking them for more data. Oh, you had a question on A1C. Why do you have that question? Oh, you have nausea and vomiting. What might be going on? Probing one level deeper. Again, some of you may not like that or might find that to be a little uncomfortable. I'm sure many patients across the spectrum will say, why are you asking me that? Are you harvesting my health data? So we have a lot of problems on trust to navigate. But imagine a world where we see misinformation rampant, digital. Most of our patients already come read with some sort of point of view on their topic that they want to discuss with you as a urologist, with your colleague across the spectrum, with me, whomever. They have points of view now, informed by a different way in which they receive health information, which is not the way they were receiving health information a decade ago. They are not reading the New England Journal. They are not reading the CDC website and thinking, and this notion that health information is somehow going to be achieved through diffusion. Hey, we're going to post something and it's going to diffuse down to the masses and they're going to do the right thing. It doesn't happen. 33% of searches on Google have a healthcare intent. That is an extraordinary number. That's trillions of healthcare search queries across the world every single month. That's incredible. And if we can make that smarter, I'm not saying it's always going to work, but imagine a world where we can make that search query smarter. Maybe, just maybe, people will start to better understand their processes, be navigated away from the wrong information, and potentially we can start to see more of the right thing happening. So that's on the patient-facing side. Google 2.0, iterative exchange, built on a generative AI platform, better information. Matters because I think we do more with less if our patients are better informed. Not just on what's actually happening inside their body, but then potentially even on ways in which they should be thinking about next levels of care if they have a better diagnostic. Well, what to do about that? Hey, maybe they can go and get better information through these iterative exchanges. That's one. Two, for you as the provider. What's your future going to look like? And I bet some of you have already seen this and are playing around with these tools. But what's Epic, for example, already embedding within their clinical dashboard in a few health systems here in the United States? Some of you may be a part of these experiments and these incubators. But what we're seeing, and I apologize for the small font here, the point here is not to read the output. It's just to show you the experience. But what are we actually seeing? We're seeing that I can have a 65-year-old patient presenting with chest pain, hyperacute T waves, high troponins, you name it, S3, lower extremity edema. What are we actually seeing? I can type that into a search field or into a search engine, or in this case, a large language model, and then spit out a differential diagnosis built on a probabilistic model, ultimately built on a large language model, millions of patient-level data points, where we're basically saying, okay, well, gosh, this presentation is interesting, and let's map it back to what it's most likely to be with all these millions of data points fed into an AI model and give you a readout of what's likely happening. That's exactly what's actually happening in EHRs now, at least in select health systems across the United States and around the world. But it's basically telling me the answer. And STEMI, unstable angina, coronary artery vasospasm, probabilistically what's most likely happening to what's less likely happening, but is actually giving, in this case, potentially a medical student or a first-year resident or a overstressed ER attending who doesn't have enough time, it gives them an ability to better understand potentially what's happening with their patients. And it's just not diagnostically. On the therapeutics, on the diagnostic and therapeutic perspective, that same patient, 71-year-old, coming in with shortness of breath, other findings on exam, the better information I have on them, input through the EHR, or on this large language model as it is today. It's a free text sort of large language model that stands on its own. The better information I have, the better the output, and it actually is telling me in this case what tests to order, what treatments to order. It's recreating how a doctor thinks. Lots here, but just to close, to say that this is happening as we speak, not pie in the sky, it's being embedded in the clinical dashboard in Epic as we speak. So imagine this world. Here, the HPI is auto voice transcribe, because that's been everything that's been talked about when it comes to Gen AI has been voice transcription. Hey, you're going to have a better way to just document. Great. And then we're going to have vital signs and labs and radiological data all be brought in. Again, better data in, better data out. This is what's happening. And so when I think about better diagnostics, when I think about at-home healthcare, and when I think about the problem of misdiagnosis, that's the ways in which I think we contend with cascading crises, demographic decline, the next pandemic, this problem of the underinsured, uninsured, people not engaged in their healthcare. It's through these real tech tools. I know I basically, it looks like, oh, you guys added a few more minutes. Okay, thank you. For those that want to get coffee, I don't want to keep you from it, but I will say I'm going to open it up. If you have questions, Dr. Nakanda, please do. There's other stuff I'd love to get to. I'm just going to have this play in the background maybe as we have a question tee up, but I do want to close on this. Because I think we can talk endlessly all day long about innovation, latest, greatest. I try not to do that. I know this might seem like, oh, these are some sexy point solutions. That's not the point. It's, hey, we have to revisit prior assumptions on diagnostics. They're not working. They work, but people are not utilizing them. I also think we need to think about how do we get payers, at least this is a US-centric problem, unfortunately, how do we get payers to cover all the amazing tools and innovations in therapeutics that are happening today? And in many cases, payers are large self-insured employers. 50% of American adults get their benefits from their employer. That's a model that's recreated in other parts of the world as well. Well, one way is actually giving employers a better way to look at their data on benefit design, on who's utilizing their healthcare benefits, who's not. And I love this. Can we actually figure out who's utilizing, and watch this, employee segmentation. Ava, at what age, what is the current age to begin screening colonoscopy? Imagine a HR benefits design for healthcare benefits has access to real-time data on what their employees are actually doing with their healthcare benefits. Obviously, vexing problem when it comes to lung cancer screening. No one's doing it. No one's screening themselves for colonoscopies. Imagine you can, in real time, for your health system, your HR benefits leader can actually identify who's getting a colonoscopy, who's not getting a colonoscopy, and then targeting actual information to a group of people that might not actually be utilizing their healthcare benefits, obviously in a way in which it's acceptable, data is protected to some degree. But imagine this. Current HR benefit design leaders get dashboard data once or twice a year. This is what somebody did with colonoscopies. This is what somebody did with their mental health, with our mental health vendor, in terms of who's actually utilizing the services that they have free to them right now. They get that view once a year. We're saying, gosh, can we give that view multiple times a year, on demand, in real time? Imagine what that could do for engagement. Anyhow, a lot there, but if there's questions, happy to take them.
Well, yeah, thank you very much, Dr. Gupta. Can I have the mic? Thank you very much, Dr. Gupta, and thanks to the audience. We have a long list of questions. We'll probably just get to one or two. We'll try to go for the repeating themes. Dr. Gupta, the first one is, what is real and what is not in the current healthcare age?
I think everything I showed you is real. The question is, do the authorities that tell us what is real and clinically acceptable, Dr. Nakanda, and to all of you, do they think it's real? And that's the push I think all of us as a profession across the world need to really be wrestling with, which is what is good? And why do we let the perfect be the enemy of the good when it comes to screening, as an example? Or with a better way to experience primary care. Mail order plus virtual care. Yes, it has its limitations. These better diagnostics have their limitations, but why are we kneecapping them? There's data showing that they're actually doing the right thing. I presented to you that slide of blood pressure diagnosis, longitudinal monitoring. These things work. What I think is not working, what's happening is there's a lot of distrust. It's faceless. Patients don't trust something that's faceless. And clinicians, I personally feel like we've gotten so peppered with the latest, greatest this or that, or a salesperson in our OR, or this, or whatever it may be, that we've lost sight of, well, gosh, what actually makes sense to invest your precious time to sink our teeth in? But there's real data here, Dr. Nakanda, to say that there's real data on these tools. I think we just have to be, one, willing to experiment with what's acceptable risk from a regulatory compliance perspective, who owns the liability. If we're saying now a Gen AI tool is going to give us a diagnosis, who's going to own the liability? So often this stuff is outside the purview of clinical expertise or the amazingness of this specific innovation. It's what are we willing to tolerate, who's going to pay for it, and who owns the liability? Sort of usual things that end up actually crushing innovation before it can reach patient hands.
Yeah, one more.
Oh, sure.
Dr. Gupta, there have been a number of questions from the audience about how to leverage technology to improve healthy living. Specifically diet and sedentary lifestyles, things of that nature.
I'll give you my take on, so just to rephrase, I guess a lot of inquiries on how do we use technology to help with healthy living. I think about this world of, we talk so much about diagnostics, better diagnostics, actually hardware diagnostics, but I think about this world of metabolomics and proteomics, other omics that will allow us to better understand very quickly, this is already happening, what should somebody be eating? What's best for their specific body in terms of consumption? Because we know that some people probably are okay eating the Mediterranean diet, but perhaps there's latitude for other people where they can do something and have perhaps a more carnivorous diet. I think there's not a one-size-fits-all approach. And as we get more into the omics field, we're going to see that people, based on their environment, based on their genetics, based on their age, should be doing certain things differently, different screenings, different eating habits, you name it. But to me, that's also a problem. That's not a problem. I think better diagnostics can allow us to do different things.
All right, listen, on behalf of the AUA and all of us in the audience, want to thank you for a fantastic lecture and a fantastic time. So thank you very much. Nice round of applause for Dr. Vin Gupta.